There's some fantastic models in London. If you want me to do it, I'm happy to do it. But actually reading the Royal College of GP's substance misuse faculty literature, I think you've got some fabulous people that are really passionate about this, who clearly have very good ideas that we could all learn from. So, what are the key levers? Well, there has never been a greater opportunity to get stuck in if you can just bear to get involved in national policy making. What are those initiatives? Well, first of all, there's the white paper. There's the NHS Commissioning Board. For many people that aren't familiar with the policy world, essentially what this new government is doing is putting GPs and consortia of GPs, so that could be GPs covering a population of, say, 100,000 people, 50 GPs getting together to commission the right services. Or it could be a consortia of 300,000 people. And one of the big questions is, who is going to provide the advice? And who's going to provide the evidence base, sensible summaries to GPs commissioning services for mental health, for substance misuse? So can we help? Who can get involved and engaged to provide that really sensible advice? Maybe that many of your organisations want to be part of that. My personal absolute plea is, when you're helping people decide what services to commission, can you include the need for people to assess physical as well as substance misuse and mental health conditions? And can your advice also be about how to engage the hardest to engage group? Give you one example. In Barnet, there's a really fantastic project called the Find the 5,000 project. And what they've done there is they identified that there were about 5,000 people who were not coming for any of the screens or checks that they needed to. And when they looked at the profile of that population, they were asylum seekers, people with no recourse to public funding, people for whom English was not a first language, people whose lifestyles just made it really difficult for them to see the benefit of any kind of intervention. So they kind of got in contact with a telesales company and a kind of social marketing company and prepared a really good comm spiel and rang each one of those 5,000 people and just explained in a motivational interviewing, really kind of helpful, just sensible language way, why it was necessary to have health checks. And in Barnet, they have now got 3,500 of those 5,000 high-risk people to come and have their checks. And their view is that it will make a very big difference to those people's health. So can we think about outreach, and how do we, do we use social marketing? I sometimes think that in your substance misuse world, you're much better at understanding the public communication needs than we are in the mental health world, but we all need to get involved. Obviously, we've got the outcomes framework. I don't know how many of you responded to the consultation on the outcomes framework. This is basically the government's new health outcomes framework. So what the government is saying is, we want to focus, we want every service that provides any sort of healthcare to think about these outcomes. First of all, prevention, which seems right spot on for what you're doing today. But then secondly, reduction in premature mortality. Can we stop this 25-year premature mortality gap? Much more about getting people to define what they mean by outcome. Does it mean employment, recovery? Does it mean that people are employed? Does it mean that people have less symptoms? And for people to have a positive experience of care. And then finally, the other outcome that the government is really committed to of the 5 is that fewer people will suffer avoidable harm. And to me, as a kind of somebody involved in senior management, that means that in my ideal world, every single person who comes into mental health services, whoever sees that person will make sure that they have had a recent physical check, which takes into account and assesses, have they got hep C, have they got diabetes, have they got coronary heart disease? And my line to my junior doctors is usually, I'm a terrible hard trainer, is, if you dare prescribe anything for a patient of mine and you have not first done the blood screening, done the physical screens, or made sure that the GP's done it, and there is a toxic drug interaction, I won't stand behind you when you end up with a coroner. And the other thing that you may be aware of, and I'm sure David's aware of because he moves in much more elevated circles than me, is that there is a significant increase in sudden deaths nationally, to the extent that ministers have now set up a special working group. And this increase in sudden death is of people in custody, and they define custody as people in prison, people in police cells, and people in mental health inpatient units. And one of the early hypotheses is that a lot of these sudden deaths are either due to unidentified and untreated physical conditions, or due to the toxic interaction between someone comes in on speed or crack, they've had a big dose of crack, and then they're given a very high dose psychotropic medication. So this is something that ministers are really on top of. So if you want to lobby, if you can think about how do you get your commitment into these outcomes framework, that would be good. And the really good news is, if you missed responding to the outcomes on health consultation, there is an outcomes on social care consultation and an outcomes on public health consultation about to come out. So there's no excuse for not putting your money where your mouth is. So can I just finish really by saying, it seems to me that the challenges we've got are workforce. How do we skill the London workforce? How do we make them aware of the knowledge that you've got about Hep C? We've driven the sequin very, very hard in London to help raise everybody, primary care and secondary care's awareness about the diabetes, the coronary heart disease, the cancer, the bronchitis, etc. In today's world, it's great when we all can get together for a conference, and I could hear from the buzz of the conversation this morning that the networking was going really well. But in this world, as we're moving forward, with the cost of training, I'm already aware of people who've been told you can't go on any more training this year because there's no money. So we have to find e-learning, technological ways of getting people what they would normally get from a actually face-to-face conference. Providing outreach from primary care, there's never been a better opportunity at all to actually get into commissioning specifications what outreach should look like. Phlebotomy outreach, prescribing outreach, engagement outreach. Pathology and phlebotomy services. You probably wonder, what is she talking about? I just, sometimes for most of us, if we listen to our patients, the things that they complain about is often not the big stuff. It's the totally practical stuff. It's how do I get to a path lab and wait for 4 hours? If I'm feeling anxious, if I'm feeling paranoid, the thought of having to get on a bus first thing in the morning, fasting, to sit in a path lab for 2 to 3 hours waiting for somebody to take my blood while I feel more and more paranoid, it's just not going to work. I think we just got to really listen to what the patients say and get out there. It's not that expensive. And I suppose my final plea is that IT systems, in many other places, in the places in the world where they have the best health and social care outcomes, it's where the IT system supports care. So an example would be that in the places in the States, for example, where they have the best outcomes, the primary care IT system is intimately linked to the mental health system, the substance misuse system, and the physical health system. So you're all on the one IT system. Worry about blood results, ordering tests, getting things back in time, it completely goes because it's on the same IT system. It's something that in London, many of us really want to start the campaign. Many of the contracts for IT systems in London will stop in the next 4 years. And if we all want IT systems that help us provide better care, talk to each other better, we need to start writing the specifications for that straight away. In my world, because I am passionately committed to helping my service users with substance misuse, even though I'm predominantly in the mental health world, I would love to make sure that people from your world are very much included in those kind of discussions and debate. So lots of challenges, and I really look forward at the end of the day to knowing what it is you want us in NHS London to do to help support you and take things forward. Thank you.